Welcome to the POWWOW.
Good evening, everybody. Welcome to this academic meet, SN Alumni GMeet POWWOW. This is the 19th chapter, and today we are discussing two interesting cases in glaucoma. Let me introduce the panel and the presenters quickly. So we will start with Dr. Shruti Shah. Dr. Shruti was with Shankar Nithalaya, Chennai from October 17 to October 19, and she also did her ICO fellowship there in 2018. She has worked at multiple places, including Bombay City Eye Hospital, TNMC and Nair Hospital, RNC Eye Hospital. Currently, she is attached to Dinanath Mangeshkar Hospital, Pune, and DY Patikal Medical College, Pune. She has special interest in angle closure glaucoma. The next speaker is Dr. Abhishek Shah. He did his MBBS from Ahmedabad, MS Ophthalm from Ahmedabad, residency at Ahmedabad. He did the clinical fellowship in glaucoma in 22-23, and he is currently working as an associate consultant in glaucoma at the Kolkata branch. He has multiple publications in peer-reviewed journals and is academically active. So our distinguished panel includes LV ma'am. No need for extensive introduction to ma'am. Everyone knows her. So she has been a member of board for many national and international glaucoma committees, and she has been the ex-president of Glaucoma Society of India with numerous recognitions to her name. Our esteemed panelist, Dr. Roni sir, he is a senior consultant and ex-director Glaucoma Services. He is director Research, Medical and Vision Research Foundations. He too has many research publications to his name and numerous national and international recognitions. Our panel today, an alumni, Dr. Rupali Nerlikar ma'am. Ma'am did her MBBS from Pune, and she did her DNB in SN Chennai in 1998 and her glaucoma fellowship from 98 to 99 at Chennai. Thereafter, she completed her FRCS. She has extensive professional experience. She is currently working at Dinanath Mangeshkar Hospital, Pune, and she has a private practice at a well-equipped center in Pune. Her special interests are angle closure glaucoma and role of lens in its occurrence and progression. And she's involved in the PG training actively and conducts CME and training for general practitioners as well. Our next panelist is Dr. Manish Singh. Sir is a senior glaucoma consultant and executive director of Netralayam Super Speciality Eye Care Center. He's also ex-honorary treasurer of the GSI and joint treasurer OSWB. He completed his long-term glaucoma fellowship from SN Chennai. He is the East Zone representative of Glaucoma Society of India and Glaucoma India Education Program Coordinator. He has more than 200 presentations, publications, and also is active in his academic circle. Dr. Mihir Lagwankar, he is a senior consultant in Department of Cornea. He did his MBBS from Pune, MS from Ahmedabad. He has a fellowship in cornea and ocular surface disorders in Chennai. He has many presentations at national and state conferences. He has interest in teaching and actively involved in PG training program, PG and fellow training programs. So I'll hand over the screen to Shruti and we will start our first presentation. Over to you, Shruti.
Good evening, everyone. I'm Dr. Shruti. I'll start my presentation. At the outset, I would like to thank Dr. Vidya for giving me an opportunity to speak here, and to Dr. Nerlikar ma'am for constantly for guiding me throughout the management of this case. So the case is as follows. A 20-year-old female resident of Maharashtra, she consulted us for blurring of vision from both eyes since 1 week. There was a history of trabeculectomy with mitomycin C done in both eyes 1 year back for query uncontrolled JOAG. As per her records, the right eye surgery was uneventful. The records did mention that she had 2 releasable sutures that were taken at the time of surgery, and both were removed 2 weeks post-operatively. The left eye had a shallow AC post-trabeculectomy and was reoperated for scleral flap suturing. Post that, the patient had a conjunctival leak with a persistently shallow AC, which was managed with a BCL. At presentation, she was on eye drops brimonidine 0.2% and timolol 0.5% in both the eyes. There was no history of ocular injury, no family history of glaucoma or long-term use of steroids, no known systemic illnesses. She was not on any systemic medication and there were no known allergies. The right eye on examination, the best corrected visual acuity was 660 for distance and less than N36 for near. The anterior segment showed a flat anterior chamber. There was an ischemic bleb present with serous, which was serous positive. The iris showed ectropion changes of ectropion UVA. The lens was clear, and the cornea was also clear. The intraocular pressure with GAT was 8 millimeters of mercury, and the gonioscopy details were not appreciated. The fundus showed a vertical cup to disc ratio of 0.9:1, with the NRR being thin and pale, and there was no choroidal detachment. The left eye best corrected visual acuity was 618 parts N8. The left eye anterior chamber was also flat, and she had a cystic bleb which had a point leak. There was corneal edema, and the lens was clear. The intraocular pressure was 11 millimeters of mercury. The vertical cup to disc ratio was 0.8:1. The neuroretinal rim appeared intact. There was no choroidal detachment. This is the video of the right eye, which shows a brisk leak away from the limbus. This is the video of the left eye, which also shows a leak, which was a little slow but close to the limbus. This is the appearance of the left eye bleb. It was a cystic avascular bleb in the left eye. Previous perimetry reports showed the right eye having advanced field loss with the temporal island remaining. The left eye perimetry was fairly within normal limits. Both eyes were managed conservatively with a bandage contact lens and eye drops, tobramycin, atropine, and timolol. The right eye did not improve and underwent a bleb revision with conjunctival advancement. The left eye, the AC had started to form, but the bleb leak persisted. This is the appearance of both eyes post BCL. The right eye continues to be flat, and the left eye AC has started to form as seen. The patient was taken up for right eye bleb revision. First, a side port entry was done and viscoelastic was injected. The superior iris was completely adhered and the adhesions were released. Conjunctival peritomy was made around the bleb. The conjunctival tissue was found to be adhered to the underlying sclera, and hence we could not excise the conjunctival tissue. The scleral flap appeared to be free with no sutures. Two releasable sutures were taken. The conjunctiva around it was mobilized and then advanced forward without any tension. This is the post-operative image of the right eye. At 1 week, the AC was formed a little shallow, but it was formed throughout. The intraocular pressure was 22 millimeters of mercury, and the releasables were there in situ. 1 month, the AC has formed. There are pairs present at the areas of side port. The lens is clear with 360-degree posterior synechia. This is the appearance of the bleb of the right eye 1 month post-operatively. There is a small leak present in the right eye at the edge. The left eye with the BCL, the anterior chamber was formed but still shallow. There is a persistent leak from the edge. It continues to be on conservative treatment with eye drop, atropine, and tobramycin 3 times a day, and has been planned for a bleb repair. I could do the gonioscopy since the cornea was clear and the AC was a little formed. The left eye showed a completely closed angle, and the right eye 3 quadrants were closed and 1 was open with few iris processes. My diagnosis is both eyes shallow anterior chamber, status post trabeculectomy with leaking blebs. Late onset bleb leaks management. Conservative treatments such as BCL, cyanoacrylate glue, autologous blood injections have been tried, but with limited success. However, with the advent of anti-metaboloite use, surgical management is generally needed. So when it comes to surgical management, the options include conjunctival advancement with or without bleb excision, free conjunctival grafts, bleb excision and use of amniotic membrane, and need for scleral grafts in any case is decided based on the basis of integrity of the scleral flap tissue. That's it. Thank you.
Thank you, Shruti, for the nice presentation. Now, taking it over to the panel, here we have come across a bleb leak which is bilateral. A bit unusual to see in clinic. A unilateral bleb leak is definitely what we come across day in, day out, but a bilateral leak points towards some patient-related factors, especially a young female with bilateral glaucoma and leaks. Any points in change of approach to such a patient where bilateral presentation has come? Any systemic associations to be looked for?
We did evaluate her. The only thing we found was that her BP was high, and we ruled out any renal or other associations. So she didn't have any systemic associations that we could pick out.
Okay, ma'am.
See, sometimes it's just a healing response. They just are very, very sensitive to the mitomycin. The second thing that sometimes happens is if you are very, very sort of compliant sclera, then even when you put your ring sutures, they don't really oppose well. So you see this sometimes in high myopes. You see it also. I mean, I've got a couple of patients with very hyperextensible joints. Skin is very, very loose. And I was expecting to see something like this, and it happened in both eyes when I did the trap. It settled down conservatively, but I think these are the places where it can happen. Other than that, I mean, sometimes it just happens. We can't do very much about it. Very difficult to predict in what is going to happen.
So anything we can do prophylactically in these surgical managements for such things to not to happen?
How many weeks post-op?
1 year post-op, ma'am.
Any habits you looked into it? Any kind, because bilateral leak is something unusual. So whether she strains and any increased valsalva, any with habits. So that can explain rubbing of the eyes. All these things can explain the bilateral issues.
We'll inquire, ma'am. Haven't really
She doesn't rub as such, ma'am. She does squeeze a little, but I'm not very sure whether that would really cause. I think the mito was too much of a mito, was put very close to the limbus rather than pushed back, and I think it was a difficult surgery right from the beginning. It just landed up in a lapse a year later. I think it must have been a traumatic course even post-operatively. They must have seen 2 or 3 other people before venturing our way. That's all.
So, how is the surface of the eye? There's no
surface is not very bad actually. If you look, in fact, we were thinking of harvesting. If we couldn't mobilize the conjunctiva, we were going to harvest it from the inferior-temporal quadrant. Surface is not very bad. There's something I don't know about the girl itself. She's slightly. I don't know. She doesn't talk, and all the talking is done by her relatives for her. But otherwise, intellect and all seems normal. She doesn't seem subnormal or anything. And she had these terrible spikes in blood pressure for which we had to postpone a surgery the first time, which they evaluated and they said it's all taken care of. So we really don't know as far as the hypertension part of it, but BP is now okay.
Maybe
There's
some
no
variant of this collagen vascular disorder.
And they all that was worked up and not found to be abnormal.
So there's no self-harming behavior.
Not that we can make out. I mean, otherwise, there's no injuries anywhere. No, and of course, very very clearly you can't tell. She's a Mohammedan, so she's all covered up. The only thing we can see is her face. But doesn't seem prone to. Otherwise, she's fine. She cooperates very well. She opens her eye properly for examination. Doesn't squeeze it shut or anything like that. Seems to allow putting of drops also quite well.
Only issue, if it is linked to any of these things, she will come back with the problem very soon.
Ma'am, they are in a hurry to get her fixed for. She's 20, no? So for those reasons, they want it fixed and fixed fast.
So in case traps keep repeating time and again, so what would be the next surgical options if the
Sometimes just giving a kind of a gel helps in just when they're coating the surface of the bleb, like nighttime before she goes to bed. Gentle gel in both eyes, so that even if she rubs during the sleep and things like that, it may help. Just it keeps the surface in a fairly better health. So that is one thing you can consider to avoid further leaks in future.
Also, maybe, madam, the behavior of sleeping, whether she's sleeping over the eyes or putting too much of pressure while sleeping, might be a possibility. But looks like when it is bilateral, there is a possibility of some systemic illness which we may not be able to find out. Not always possible. A lot of time we can't diagnose them. But since it's bilateral, if it's just a young age, patient has hypertension, so there is some systemic problem she has. We may require some further investigation to the point. And I think if she, I think currently also she's leaking in both the eyes.
Right
eye, it's a very slow leak. Not really a brisk leak.
I had just trimmed the sutures like yesterday only, so one day prior. Like, so I don't know if that could have I don't know if that could have contributed to it. So.
What is she currently using in right eye?
She's on ectropion eye drops, sir. Yeah. And we've added tobramycin also because of the leak.
Is the chamber very shallow in right eye?
Right eye, just temporarily there is synechia at the side port, otherwise it's formed.
We had a patient like this, bilateral patient, had young patient with juvenile glaucoma. The patient also had associated macular dystrophy. And patient had a trap done in both eye and both eye leaked. And one eye, luckily with a conjunctival autograft, patient responded well. But the other eye continued to leak for 3 years. Even after bleb repair, patient continued to leak. So sometimes it may never heal. You may still have to go ahead and do more surgeries because these areas are necrotic and they have issues with healing. And we had another patient where we thought it's a very minor leak, may not harm, but unfortunately patient came back with a very bad blebitis. So even such minor leaks can be dangerous. They can.
So in such patients, can we suggest skipping the antifibrotic intraoperatively?
Next, if you have done one eye and had a bad experience, then you can skip it in the other eye. But this patient already both eye have been done. So I think future, if you're doing a surgery, probably you will not be doing a trap. I remember Ologen was one option when you had a very bad experience in one eye mito. We often used to try Ologen in the other eye. Probably it's not available.
See, the other option you have is to go limbus based if you're doing the second eye.
Yes.
So when you go limbus based with the more conservative mitomycin application, the edge issues are much less, provided you do a large area and all that.
With that, a picture which I think Dr. Shruti showed, sir, it was little behind the edge. It looked like a millimeter or two behind the edge. Was it, madam? Rupali, madam?
Yes, sir. The right eye was beyond the limbus. The left was still close to the limbus.
But it's on the top of the bleb. It is not leaking from the edge.
Not edge.
It is a very thin cystic area of the bleb which is leaking badly.
I think cutting down mitomycin in the other eye is a good option.
I had a question for the panel. Can we try autologous blood? Like, I don't know, would it help for a point leak or no?
We have tried in 2-3 cases. Doesn't really work much because once you already necrotic blebs, it doesn't work. If you still see some vessels around, it's not totally necrotic, then the autologous blood can induce more fibrosis. But if it's a totally avascular bleb, then it will not help. Maybe it can temporarily increase the pressure for a month or two, but then again it will come back to.
I have a little difference of opinion, and if you have a micro leak, single point leak, yes, you can try. If it is a large leak and multiple leaks, it doesn't work. So one way of doing it will be, along with autologous blood, you can apply what we call it as a compression suture. So that kind of reduces the height of the bleb. At the same time, the micro leak gets benefited from the autologous blood. So the vessels also try to grow from the surrounding area. You can have some amount of fibrosis. So ultimately, you have to make sure the leak heals. You cannot leave the eye with the leak under any circumstances. If it is not working, you have to go ahead with a next option. excising, seeing if there is a sclera, you may have to reinforce with a patch graft or make a flap adjacent to it from the sclera, partial thickness scleral flap, cover it up, put the conjunctival graft. So you cannot leave anybody with a micro leak or bigger leaks forever.
Okay, so in conclusion, we see that to start with, to follow the safer surgery techniques, and if at all things do not work, blebs leak, then to manage conservatively depending on the location, site, number of leaks, and in case of extensive leak, to go for a extensive repair directly. Okay, so systemic evaluation in young patients if repeated leaks or bilateral leaks occur. Any other query from any other participants regarding this case?
So I have a question for the panel, just for the, because it's an important point which we often face. When you remove these necrotic blebs, so sometimes you have this dilemma whether to put a scleral patch or to just do a conjunctival graft. Because putting a scleral patch has this disadvantages that the pressure may shoot up, and then managing the glaucoma again later on becomes a problem. Because recently we had a patient who had a 10-year-old surgery, came with a leak, blebitis. We operated and it was totally necrotic, so we had to put a scleral patch. Now the pressures are around 40, which was in the range of 6 to 10, juvenile glaucoma. So then now that part also becomes difficult. So I'll request some of the panel how they decide when to put a scleral patch and when not. And if they put, is there anything trick we can use to sort of not have very high pressures? Maybe use a thinner flap, partially cover the necrotic area. Any tips, sir? Ronnie sir or LV madam?
Well, so basically, once you have opened the conjunctiva, you look to see how much leak you have. And if it is profusely flowing, then you know that you need to do something for the flap. I mean, you need to actually close the sclera some way. And typically, when you're doing a scleral patch, then what I tend to do is I anchor the anterior portion firmly, and the posterior portion I actually put releasables. Okay, so then if early on I notice a pressure increase, I sort of release that.
Sir, one of the postgraduates has a question for you. Indications for limbal-based and fornix-based conjunctival incisions in trap.
Yeah, so basically, I mean, we almost all of us now do fornix-based surgery. Basically, essentially, since a large area application of mitomycin made these blebs much safer. So you open a large amount of the conjunctiva, you apply the mitomycin at a low dose all across it for the minimum possible time, you wash it off thoroughly, and then you close it meticulously. So with the limbus-based flaps, the problem was that you were getting overhanging blebs or you were getting localized cystic blebs. So that's the reason that we moved away from them. And so even, I mean, most surgeons in SN are trained in both techniques, and most of us would still do mostly fornix-based. And limbus-based I tend to do in cases like this where I'm worried about a wound leak. Sometimes very active young children, I tend to do a limbus-based because it's very difficult to keep taking them to theatre if you have a problem. But other than that, by and large, maybe 99 out of 100 times, it's going to be a fornix-based.
Okay, so that was a nice discussion. Shruti, I hope most of the questions regarding this case were answered, and so everyone will be more cautious in dealing with these patients henceforth. Coming to our next presenter, Dr. Abhishek, I would request you to start your case presentation.
Okay. Very good evening, respected teachers and colleagues. Today I'll be discussing about an interesting case of descemet membrane detachment following trabeculectomy in a patient with bilateral congenital ectropion uvea with primary congenital glaucoma. So this is a case study of a 12-year-old child, a female child. Parents presented with gradual painless loss of vision for past 6 months, and they noticed enlarged eyeballs since early childhood. and there was no history of self-medication or trauma. And she was already started on topical dorzolamide eye drops, and she was using it for past 2 months in both eyes. Rest of the antenatal and postnatal history was not significant, and all the other siblings were apparently normal. She had a base corrected visual acuity of 6/24 and 6/18 with significant astigmatism in both eyes. And on the slit lamp examination, we could see that both eyes had stretched limbus and megalocornea with corneal diameters ranging in range of 13 millimeters horizontally and vertically. Deep anterior chamber with ectropion uveae in both eyes. Lens were clear. Intraocular pressures with on one medication was 42 and 28 millimeters of mercury. And she had, on gonioscopy, she had high insertion of iris with a little bit thinner pachymetry. She had a very advanced damage in her optic nerves, and which showed similar results in the visual fields. So we came to a conclusion of diagnosis of bilateral late onset primary congenital glaucoma with congenital ectropion uvea with advanced glaucomatous optic atrophy. So patient was started on maximum medications, and she was getting prepared for mitomycin augmented trabeculectomy in both eyes, right eye first, followed by left eye. So intraoperative course was surgery went uneventfully. The post-operative IOP remained in the range of 5 to 7 millimeters of mercury till she came for final visit at 1 month. On the post-operative day 2, we noticed a small temporal descent membrane scroll, which gradually started increasing towards inferiorly, almost spanning 180 degrees. And on the post-operative 5th day, she also developed corneal edema. So we started on her topical hyperosmotics. When she came for the final visit at 1 month, the inferior descent membrane detachment was scarred and the edema was subsiding, but the central visual axis was clear. This was the SOCT which confirmed our diagnosis. There was no leak, and IOP was 7 millimeters of mercury with a diffuse bleb. So when we operated for the left eye, it was important to take care of the prophylactic measures. So at the end of the surgery, intracameral air was injected to avoid any descent membrane detachment. So this is the post-operative course of the left eye, and by the end of 3rd day, the air bubble was absorbed. There was no leak, diffuse bleb. IOP was between the range of 5 to 7. But on the 5th post-operative day, we saw superior descent membrane detachment in this case. But there was no edema by the end of 1 month. So no treatment was done. And this was the anterior segment OCT, which showed at the end of 2 months post-operative for both surgeries. And it showed still the descent membranes were detached, but the central pupillary axis area was clear. So in this case, we might be thinking that gradual stretch on the globe may not cause herpes striae, but clinically undetectable microtrauma to the descent membrane, which got worsened during intraoperative manipulation and globe decompression. Even though in the other eye we put intracameral air, but it showed the similar outcome. There have been a few case studies in past. There was one eye which had post-operative flat AC, and on slit lamp they had injected viscoelastic in anterior chamber to form the AC. Followed by there was a descent membrane detachment. There was a case of spontaneous descent membrane detachment from Hub's trial, but this patient was on long-term topical carbonic anhydrase inhibitors. There was no intervention done before the descent membrane detachment was spontaneous. There have been many studies showing what changes happen in primary congenital glaucoma, and almost 44% of the eyes had half striae in this study, but none of the patient had descent membranes detachment. As far as we could find, this was the first case showing such bilateral descent membrane detachment following trabeculectomy, and we come to a conclusion that maybe use of topical carbonic anhydrase inhibitors, high intraocular pressure, and surgical intervention in such large stretched eyes might pose a risk DM detachment post-operatively. But since the central cornea was clear, all we had to do was just follow.
Thank you, Abhishek, for the nice presentation. I'll again take the case to the panel to discuss regarding these pediatric cases, the ophthalmic eyes, if these are common occurrences, corneal involvement, descent detachments, are they common, or there are few variants which present with these cases?
I have actually not come across this very often. I mean, I can't recall, maybe once. But what I can tell you is that some years back, I operated on this lady. I did a cataract surgery on her, uneventful cataract surgery. Finished 2 post-op visits, and she turned up after 10 days with a complete descent detachment, spontaneous. Anyway, we just managed conservatively, and she settled down. I did the second eye after some time, put a large bubble, and again, first post-op, second post-op day, she's fine. Came on the 10th post-op day or 15th post-op day with a complete descent detachment. And this time she brought her mother along with her. And she said, my mother also had something, she required a second surgery or whatever. So you take a look at her and you can see folds on her corneal endothelium, very typical of a reattached descent. So there are some people who are just prone to this. So I think your patient is probably just one of them. I don't think it's anything that you did. The only challenge is when you do a trab, when you leave a large bubble also, it doesn't really stay there for that long.
Yes.
So some of it is leaky, unlike a cataract where you can leave it and leave a slightly better film. So, I mean, I think that's the more, because this happened in both eyes in spite of all precautions, I would think it's more a patient-related factor than anything else.
Okay. So from the management point of view, if it involves the visual axis,
Yes.
so we will need to intervene.
See, if it involves a visual axis, it's a child, sometimes it just settles down conservatively. It just settles down, especially if it's attached, if you're seeing portions of attachment. If it's rolled over, then yes, you have to go in and do something. If it's not rolled, you can sometimes get away with nothing interventional. The case that you described, Abhishek, that you presented, so there when you've injected viscoelastic at the slit lamp, you've probably gone between the DM and the cornea, and that's why it detached. I don't think it is, and with the shallow AC also sometimes this can happen because your DM gets stuck to the iris and you can get a localized tear.
Yes.
But otherwise, I would be conservative, give it a couple of weeks. If it doesn't, then you go in and put a bubble or switch it. I think Shruti is on this call. She's probably got more experience dealing with DM detachments than anybody else around here.
Yeah. No, these congenital glaucoma eyes, the stretch of the eye cornea is much more also. So the elasticity of the descent membrane is different from the elasticity of the cornea. So that can also be one reason where it can either disinsert for the Schwalbe's line, because whatever it is, we make a entry into the eye before we punch. So that can be a reason where it scrolls, or if you have a hab stray, then that margin can separate out. And even the instrumentation, after we enter, when we put in the punch, that time also we may be nudging at the free edge of the descents and separating it out. But like Dr. Ronnie said, we cannot oppose it back as well as the cataract patients. And young people, the recovery of the eye, it also depends on the endothelial health. If the cornea was reasonably healthy prior and it is a congenital glaucoma, they spontaneously resolve. But if it has been an ignored eye and overall the corneal clarity itself has come down because of endothelial loss, then they will need surgical intervention before they settle.
Okay, ma'am.
Should she warn her child's mother or parents before the cataract surgery? They should get their ASOCT or something done. If you're saying it can run in families, just a thought.
No, that's fair enough. I mean, there's no point doing an ASOCT. Just tell them that this might happen. Because there's no signals anywhere. Very, very difficult to. I've seen this happen. I mean, this is the only familial one I have. But I've seen this spontaneous happen 10, 12 days, maybe 4 times.
And so this is OCT study by the AIMS group where they have said there's a double desmites or a PIDL. I mean, could it be that or this is different?
See, if you look at it, if you look at the edema that happened after the detachment and then followed by scarring, it looks very much like the DM. The median would really expect that to happen.
So I would like to ask the cornea panelist if management in these eyes will differ in any way from a normal eyes, because the AC depth we saw in one of the findings was 5.3 millimeters. So definitely injecting that big a bubble and making it stay there itself was difficult. Can Mihir opine on, because Mihir was seeing this patient?
Good evening. Can everyone hear me?
Yes, yes.
Yes, Mihir.
Yeah, thanks everyone for having me here. So, yeah, definitely what has been described in books is that congenital glaucoma can be a cause for, can be one of the risk factors for descending membrane detachment after an intraocular surgery. And in this case, definitely the management, we had a conservative management because the going by the algorithm, what the books describe for descending membrane detachment, it was not in the visual axis, and it was a planar detachment with no scrolled edges. And definitely air tamponade would be difficult post trabeculectomy with a deep anterior chamber, and especially in a child where a supine positioning or obviously in an inferior detachment, having a extension of neck for such a long time, all these challenges would have been there. So definitely difficult to manage these cases.
So this detachment happening in a otherwise healthy cornea and any corneal pathology along with the glaucoma.
Yes.
So having both associations together may make it worse. So
yes. So
one other thing is where the desmites died.
Yes, ma'am.
Sorry.
Yes, ma'am.
Yes.
No, please, Mihir, you continue. Sorry.
Yeah. So one thing that this case had a ectropion UV, but we have taken a slit lamp photograph. The cornea looks, the corneal endothelium looks fairly okay. No other probably associated dystrophy or anything which is evident from the slit lamp photograph. And obviously, I saw the patient after the surgery, but even before also the slit lamp photograph, which apart from the ectropion UV, so certain dystrophies have been associated with congenital glaucoma, certain congenital corneal opacities with glaucoma, obviously, and so one interesting thing about the posterior polymorphous corneal dystrophy, which is a rare dystrophy, and it has this sort of some of the features of posterior polymorphous corneal dystrophy. The endothelial cells proliferate over the trabecular meshwork and over the iris like an ICE syndrome. That's what has been described in books and literature. So probably obviously this case is classically presenting like a late onset primary congenital glaucoma, but could be one thing which can be associated. Although there are no other features which are suggestive of any corneal dystrophy.
See, previous literature used to talk
Manish.
about the duplication of the Descemet's membrane and all that. With the realization that we have a Duas layer, what literature states is that if there is a Duas separation, then there is a higher chance of it spontaneously reattaching. Whereas if it's with the Descemet's, then it tends to be much more difficult to reattach it without intervention. That's what it says. So sometimes
ma'am.
what it goes back is probably just a Duas separation, right?
Sorry, ma'am.
It did not reattach. It did not reattach on its own. It just scarred and
In this
stabilized
case, yes.
there.
But when it spontaneously reattaches, they say that it may be just the Duas separation. Because previous all the literature, we did not know there was a Dua layer. So if it's Dua layer alone separate, then the chances of it reattaching are much more pre-Descemet's layer alone than with the Descemet's membrane.
True, ma'am.
Okay.
True.
Vidya, one observation I like to share. Since the patient is having bilateral DM detachment, there is very good possibility that the Descemet membrane or endothelial might be having some dystrophy, or it's not a healthy endothelium. That is why it is having the bilateral. And again, going to the first question which you asked, how common it is. Actually, it's very, very rare. I think most of us might not have seen so. We'll be doing traps so regularly. How many DM detachment we see? Even in congenital glaucoma, it's very, very rare. Good possibility there is some problem with the endothelium. And looking at the eye, apart from ectropion uveae, the iris was also has very little structural stuff of iris. If you see, like hypoplasia type of iris. So whether there were any other signs of any iridocorneal dysgenesis, maybe it's not a case of primary congenital glaucoma, but iridocorneal dysgenesis or axon field variant, whether there are any other systemic features which might be we were dealing with the case of iris with corneal dystrophy, that could be the reason why patient presented in this way.
As such, the physical and mental growth were fine. No other systemic associations, no facial features suggestive of any syndromic association. So, but definitely in such cases, we should look for these. There's a question from Shikha ma'am. In a cataract surgery, what intraocular changes could have caused a spontaneous DMD on the 10th day? Is it a corneal decompensation or DMD? In Abhishek's case, ASOCT showed a bulky stroma.
I didn't see it very properly, so I might be wrong. Everybody is calling it DMD. Maybe it was a DMD only. But if you show the ASOCT, it just looked. I would like to see where the DMD you showed in that ASOCT, Abhishek.
It's visible, Shikha.
Maybe I missed it. Everybody is saying I wanted to know, Ronnie, what could have caused 10th day spontaneous DMD?
I've been wondering for 15 years, Shikha. I don't know the answer. It's been described.
It was the hypotony.
No, nothing. There are few
it's
cases.
The endothelial dysfunction that is suddenly causes the fluid to collect there. I was wondering, thinking aloud. 10th day.
Not really sure, Shikha. There are a few other isolated case reports of these spontaneous detachments, and they say sometimes the attachments membrane, the Descemet's membrane attachments to the stroma are probably not are unhealthy or whatever, are abnormal.
Great, thanks.
Thank you, ma'am. Anyone else wants to add anything in this case? When we had a few years back a Sturge-Weber syndrome child who underwent trabeculectomy, even he had Descemet membrane detachment away from the trap site, but it was scrolling. It was 2 to 3 millimeter scrolls in 2 to 3 areas, which were immediately seen post-op day 1, and the scrolls remained. So we assume that these are because of the sudden decompression that happens post-trab in a stretched globe, that the area of Descemet membrane is now different than that of the cornea, and so the remaining desmet scrolls in. These are at the edges, not very apparent, but if you keep looking, some scrolls were seen. Okay, so are there any questions from the attendees? In case of no questions, then I would hand over the screen to Mona ma'am.
Okay, thank you, Vidya, and the SNK team for starting the glaucoma chapter of the POWWOW from SNK. I thank Dr. Vidya, Dr. Abhishek, and Dr. Mahir for being here, and also Dr. Rupali and Dr. Shikha for sharing their cases. So what we learned, I'll just make a small summary of what we learned, like I usually do. So we all looked at the problems which we can have post-trabeculectomy, especially in the young. Bleb leaks, we started with bleb leaks, which can be challenging, but we need to take the challenge head on and always plug the leak in whatever way possible. You can start with the intraoperative precautions and sometimes even go as far as doing a limbus paste, like Aji sir said. Of course, with diffuse mitomycin application, and post-op, you can have multiple ways to plug the leak, like your conjunctival or advancement conjunctival graft, a scleral patch graft with the releasables to keep the pressure low, or in case of pinpoint single leak, like LV ma'am said, you can do autologous blood injection with compression sutures, depending on the case-to-case scenario. The DM detachment post-trap can come as a surprise because that's something you don't expect. You didn't touch it. So it's very challenging, and sometimes it may be surgeon-related factors which we should avoid, like we have discussed, like making the side port with a sharp knife, don't hydrate in between the layers, and slow decompression. But sometimes it may be just patient-related factors, and if it's peripheral, like here they managed it with air or conservatively, but if it's in the visual axis, you may need to be aggressive. And so these are the few take-home messages which are there. And thank you all the panelists for the wonderful inputs. Hand over to Dr. Shikha.
Great cases and even better discussion. Really learned a lot. Thank you, everyone. And really, where this POWWOW was done very, very professionally. Thank you, Dr. Vidya. I mean, like right from the getting the speakers and panelists and your flyer and everything was great. Everybody logged in earlier and uploaded their talks. Great.
Thank you for the kind words, ma'am. Thank you so much. It was a nice experience. I thank my seniors also for the guidance and agreeing spontaneously for participation. Thank you so much. I thank Shruti and Rupali ma'am as well. Thank you, Emeka ma'am. Thank you so much. Thank you, Manish sir, for your valuable time.
I think you for publishing the case, I remember.
Yes. Thank you, Mihir, for attending the glaucoma con CME. Thank you so much.
He had no option.
Can we have a photograph? Cameras, please. I'll take a photograph for the